Thanks to the tireless efforts of Jonathan Simons and Dr. Howard Scher, who I'm going to introduce in just a second, prostate cancer is a case study for what this fine group hopes to achieve. So I will introduce Dr. Scher, who I think you all know. He's the chief of GU Med-Onc at Sloan-Kettering Cancer Center and a veteran PCF kind of guy. Howard?
Thank you very much. It's really a privilege to represent a team that's now working together to try to bring all of these exciting discoveries and advances to man and to improve the outcomes of our patients even further. As you've seen over the past few years, the therapeutics in prostate cancer have advanced dramatically in large parts through the efforts of people in this room, both really on every dimension, including scientific, patient support, foundation support, and obviously team science. So what I'd like to do is represent a team that is now trying to focus on reducing the enormous amount of information that we're now faced with on the daily basis to see how we can bring this to impact and improve the outcome of both the individual patient as well as populations of patients. If I could have the next slide, please. So prostate cancer really presents a bit of a paradox. We know that there's a high prevalence of the disease in the population, and in recent months, there's been a tremendous focus on overdiagnosis and overtreatment of the potentially insignificant cancers. We also know that in many men, the natural history can span 10 years or more, and in many cases, the safest option is really to observe the disease and allow it to declare itself or not before making a decision on whether to proceed with a more aggressive approach. We also know that this is an elderly population, and unfortunately, we will all die of something, and in many cases, the comorbidities are of greater consequence to the individual than the cancer itself, yet this remains the second leading cause of cancer deaths in men. We have also seen situations where the disease evolves more aggressively, and following the elegant presentation by Dr. Garraway, we have more food for thought on how we unravel potentially these different mechanisms of progression and whether there are therapeutic opportunities here. But what we often underestimate is what is the effect of the actual treatments that we're administering to patients on the tumor itself. And this is the type of information that's often not adequately captured in patients who are enrolled in clinical trials. So in the early 90s, as the Prostate Cancer Foundation was seeking to bring a group of clinical investigators together, it was essential that we develop a database in order to house this information. So typically, we were looking at pathways, and in one particular case, if you tried to follow all the possibilities, even in the 1990s, you can come up with over 2,000 different routes from a patient from early diagnosis to his unfortunate demise. So we hypothesized that it would be more important to think of milestones in the disease that would allow us to organize both how we approach patients, how we approach clinical research, and so we developed what we call the clinical states model, which are really milestones in the disease, easily recognized and simple, and I would argue straightforward, starting with the patient who may be at risk for prostate cancer who has no cancer diagnosis, the patient who has apparently localized disease, the patient who has undergone primary treatment, let's say with a radical prostatectomy, and now has a rising PSA as the sole manifestation of the disease, to the patient who's been treated with hormonal therapy as the standard first-line approach, which we call castration-resistant for reasons because the biology of the disease is such that these tumors remain hormone-driven, as proven by the recent success of both Zytiga and, as of last week, enzalutamide, which you'll be hearing about from Charles later on. So again, if we think of this disease in terms of milestones, we now have a framework in which to organize our databases and our research. So think of the patient with localized disease. The unmet need for the individual is how do you understand what is the biologic significance of his tumor? Is it one that is likely to metastasize early and potentially lead to symptoms or death from his disease? Or is it one that's just been sitting there for a number of years, which is not aggressive? So the unmet need is how do we tailor the approach based on the profile of that particular tumor? And the therapeutic objectives include minimizing morbidity and avoiding over-treatment, which is why active surveillance has become more prominent, particularly as we are finding many indolent cancers earlier and earlier. So again, this frames the clinical questions as well as the research questions. If we look at the various clinical models that are out there, there are probably over 100 models for the patient with localized disease. And this is just a cohort of patients who were evaluated based on Gleason score, clinical stage on digital rectal exam, and baseline PSA. This is the same population on the left, analyzed by different criteria, and you can see that the range of outcomes is quite broad. So the clinical parameters alone really do not predict well, or there can be a range of predictions based on the same data. More importantly, many of the events on which we're basing our outcomes, in this particular case, PSA recurrence, don't predict for ultimate death from disease. So clearly, we need other intermediate measures post-treatment, which will allow us to understand which tumors are potentially lethal, which need aggressive treatment earlier before they have had a chance to cause symptoms. Now, the stakes are obviously higher in the patients who've progressed on hormones, particularly for the patient who has metastatic disease visible on a scan. But here again, the issue is, what is that individual prognosis? In some cases, it may be less than a year, in others, multiple years. Now we're beginning to understand some of the molecular alterations in tumors that allow us to select specific drugs. And this is what we call predictive medicine, predictive biomarker, in order to practice what is now termed personalized medicine, or more appropriately, precision medicine, tailoring the drug to the specific molecular alteration within the tumor. We also have the issue in prostate cancer that most of the metastases are to bone, where it's very difficult to assess outcomes. So we were forced to recreate rules that were appropriate for the clinical trials that we're doing, that enable us to understand the effects of treatment, which is why we thought about eliminating symptoms, controlling disease if it's present, and preventing or delaying new significant symptoms such as pain, spinal cord compression, or ultimate death from disease. And if you see in the past 3 years, there's been a dramatic change. Notice that as of 2004, only one drug was approved. Now there are 4 additional agents. And in particular, what was a paradigm shift in management was the suggestion to use a hormonal agent after a patient had progressed both on chemotherapy, both on hormones as well as chemotherapy. But the approvals of abiraterone and enzalutamide were both based on phase 3 trials that showed a survival benefit first in this population and are now being moved earlier into the course of the disease. What are the issues going forward? How do we identify the specific alterations within a tumor that predict for response? And if we look at the outcomes with Zytiga and enzalutamide, you can see that there are patients in whom there are dramatic responses. There are patients in whom there appears to be no response at all, simply based on the PSA change, which suggests that there are, in fact, biologic predictors present within these tumors that, if we can find them and identify them, would allow us to better tailor approach to the individual patient. What else? We have to understand, how do we combine these agents? How do we sequence them optimally now that we have multiple choices? What are the tests that should be performed? We have a lot of new imaging techniques, but often these are difficult to get reimbursed. And we know that we need to do a sufficient number of tests, no different than the way we conduct a clinical trial, in order to understand what type of information these tests might provide. We also have to figure out how often do we use these tests in order to maximally inform trials, and how do we interpret them? Because if you look at, for example, the sequence of scans shown here, this is the same patient imaged by 3 different modalities: the standard technetium bone scan on the left, a glucose FDG PET scan looking activity within individual lesions, and a fluorinated dihydrotestosterone scan, which is actually looking for the presence of the androgen receptor, which is a test we use in order to guide how to optimally dose the androgen receptor signaling inhibitors you'll hear about from Charles. We now know through work started by Arul Chennai and Ken Pienta and others, and a presentation by Levi Garraway, that there are many different alterations that we can start looking for in these tumors: structural rearrangements, copy number alterations, point mutations. But to date, we haven't found at high frequency the types of mutations that are druggable, as have been found in colorectal cancer and lung cancer, in order to appropriately guide management. We are finding them, however, in rare populations, which suggests that we need to do this effort much more globally. We also would like to be able to follow the evolution of the tumor, again, as we heard how these tumors change. But we also have to pay careful attention to what specific treatments the patient has had, because as we've seen in laboratory models, this too could modulate the disease. And one could postulate a tumor that's progressing on chemotherapy versus another one progressing on hormones may have potentially different drivers. So just to illustrate, we typically look at a patient of what is this current status, what is happening with this patient today. We look at each visit as a start over. I think of it more as a computer game where you want to load all of the previous information, which includes the characteristics of the disease at the diagnosis, as well as the prior treatment to which the patient has been exposed and the response to that agent, recognizing that the tumor is likely to be influenced as well by the specific treatments that has received. Clinical trials are the gold standard of evidence in medicine, but really only 3 to 5% of our patients actually go on a clinical trial. And if you actually looked at 2006 of the trials that were open for lung, breast, and prostate cancer, 238,000 patients would have been required, which represented half of all the cancer incidents in the United States. But the real problem is that we're drowning in information, and often we don't have the right information at the right time in order to make a decision on how to approach an individual patient's cancer. This is all happening at the same time that bureaucracy is increasing, and systems are really needed in order to enable our interactions with payers to be more of a collaborative one versus an argument on whether a specific test needs to be performed at a specific time. It is essential that we generate the evidence to show the utility of those particular tests. So if you think about why would we be interested as oncologists in a potential capability with Watson. So if you could fantasize what might be available to you, if you would be able to have a system that could ingest all of the data relevant to an individual patient, translate some of the notes that we write and dictate in the management over time, look at the medical literature at the same time and keep us up to date about what might be potential supporting evidence for one approach versus another, get a ranking order of which might be the more appropriate as a guide, and also to be able to learn from prior experience. And it's for this reason that Memorial Sloan-Kettering has embarked on a collaboration with IBM Watson. And it's my privilege to introduce Dan from IBM, who is the Vice President of Watson Marketing, and will be presenting the IBM side.
Thank you, Howard. I think we have a video.
Over 12,000 diseases in the world. Some take years to diagnose and treat. How can doctors find insights in a body of medical knowledge that doubles every 5 years? New solutions based on IBM Watson are being developed to help doctors analyze a patient's history, symptoms, and the latest medical literature to make faster, more accurate diagnoses.
Hello, my name is Watson.
Let's build a smarter planet.
On behalf of IBM and my colleagues, I want to thank the Foundation for giving us an opportunity to share with you, in the spirit of celebration of science, what we think is a breakthrough that we hope helps this cause, cancer treatment in general, and indeed medicine and healthcare in general. I'm assuming that most of you know something about Watson, so I'm going to move in that direction. I'll tell you a little bit about the system, but the significant thing was about a little over a year ago, a system proved that it could compete with human beings on a game show. Obviously, our goal wasn't to play games, but it was to demonstrate some breakthroughs in technology that were required to advance a number of things. And that was namely the ability to understand human language. I mean, really understand human language. And to compete in Jeopardy, that means that you have to understand and answer a question with a single answer in 3 seconds. And we did okay. And we think that this technology has promise. So one of the first questions that we face is, where do we apply this technology? This is technology that most computer scientists said would not happen in their lifetime. So when we demonstrated the ability to understand human language and answer questions, this was a major, major breakthrough. And the question is, what do you do with this technology? And the first place we're applying it is in healthcare, in medicine. And why, we all know, right? Our healthcare system, especially in the US, is broken. The costs are out of control. The costs The waste in the system is estimated to be 33, 34%. There are shortages of docs, especially around the world. There are movements towards accountable care organizations that are stymied for a number of reasons. Right? There are trends towards evidence-based medicine and personalized medicine, which we all believe hold tremendous promise. But the reality requires better information systems than we have today. And we think these technologies can make a difference. The data that exists, the information that's available to us is overwhelming. Right? I think we all know that the medical data doubles every 4 to 5 years. That's the estimate. That is before you start talking about genomic data. The amount of data is overwhelming. On the patient side, biomedical markers, Fitbit devices, personal iPhone EKG applications. I don't know if you've seen these. The number of devices that exist that will generate patient-specific information is overwhelming. And on the other side of the equation, targeted therapies are promising. But the job is to match the patient's situation and their disease condition with the targeted therapy. And that takes work. This overwhelming volume of data is not just a healthcare issue, of course. It's rampant everywhere. Right? So as an example, and we won't dwell on this, but in IBM we talk about the 4 V's of information. And the volume of information being generated, for instance, in social media, which will be helpful in learning about a patient, in learning about their recovery. And just as a small example, is an opportunity. Data is an opportunity, not a problem. On the left side, there are 2 facts that are always flabbergasting to me. 90% of the world's data was created in the last 2 years. That's mind-boggling. Right? Just as mind-boggling is that 80% of the world's data is unstructured. Right? Unstructured means it's not in a table. It's not quantitative. It's not in a database, or at least it's not in a traditional database. And consequently, it's very hard to process. This technology allows us to process unstructured data. These technologies I'm going to talk about are transformative in a lot of ways. As I said, understanding human language, answering questions with a single answer, and then adapting and learning will change computing. And we're hopeful that these changes will usher a new era of computing. We could talk about this for hours, but I won't today. But it's important to understand that there are technologies being developed in the labs and in practice across the world that are changing the way computer systems work. There's a lot of talk about big data. Right? Big data is a class of technologies that deals with some of this opportunity. Right? And we think this is ushering in an era of cognitive computing. Right? I hope this is the first time you start to hear about cognitive computing. That is a class of computers that learn. Traditional computers are deterministic. Programmers write programs, and they do the same thing over and over and over again, and that's a great use of computer technology. But cognitive computers are driven by the data, which changes, of course, and they learn over time. And these are very powerful innovations. Let's shift to Watson and Watson for healthcare. I'm not going to present this. This is just a high-level schematic of a massively parallel system. This is not a single technology. This is not a single application. There's over 100 technologies buried in the Watson system based on 15 years of research and development. So this is a very complex system. The challenge is adapting it to our first domain, which is healthcare. So as Howard said, imagine if. What if you could read virtually everything you needed to read as a clinician and remember it and then instantly recall it? And I'm not suggesting that doctors can't do that. But there might be some who are unable. Right? And clearly, 3 to 4 times the number of docs, caregivers outnumber docs 3 to 4 times. And they don't have the medical training and experience. Clearly, we ought to be able to build systems to help them. And that's what IBM is investing in. In summary, imagine a Watson for healthcare system in which we ingest all the information we need. It's virtually limitless. It's a matter of time and computing power. Now, that's not free. We have programmers. We have programmers who write things called annotators that learn about specific classes of information, and we feed it into the system. and it gets stored in many complex ways. In fact, it gets stored 10x the information that we ingest gets stored. So we take it in. That forms a basis. That's a repository. Next step, run an inquiry against that repository. Ask a question. Now, what's a question? In Jeopardy, it's a simple question. In real life, it's effectively my complaint. Right? This is my situation. Here's my medical file. Here's all the doctors and nurses' notes in the file. Here's my lab tests. Here's your observations. Right? Here's what my family said about my condition. That's an inquiry. The question is, what might be wrong with me? Right? This technology is able to understand that inquiry and then speculate on topics, hypotheses, that might be relevant. Those hypotheses are then run against that repository, looking for evidence to support them or refute them. So what you'll get is you'll get a small number of topics. There's a curve with a long tail. A small number of topics which appear to be highly relevant to this particular inquiry, right? This disease, this condition that I'm dealing with. Those are then ranked. So programmers, human beings, develop and refine forever scoring algorithms to help take that evidence and figure out if it's relevant to the particular question. And then an answer, actually a series of answers with a confidence level is presented. So this isn't a single answer in 3 seconds. That's not how medicine works. It's a series of answers with a confidence level, 90%, 80%, 20%. Clearly 3 answers in which one was 90% and 2 are 10%. It gives me a message. The system is telling me that the system thinks this is a good answer, and it will show you the evidence. On the other hand, if there are 6 answers and they're all 18 or 20%, then clearly the system doesn't know enough yet. You'll have to interact with it to see if there's better answers. That is how this system works. It's big, it's complex, but we know how to do it. And the important thing is that it learns. The system is not magic. It's something called machine learning. So what we do is we train the system. We spend working with our friends at WellPoint and our clinical friends at Sloan-Kettering and other institutions. We figure out how to train the system about medicine and about cancer and about specific diseases. And it's an arduous process in the same way of educating anyone. But over time, the computer learns and it refines and it remembers. And that's the basis of this technology. So the question is, what are we going to do with it? We have built and we are building a platform called Wotton for Healthcare. Wotton for Healthcare is an IBM and partner system that we are making the investment in. I'm talking about hundreds of millions of dollars to build a system that knows about medicine. And it will take years. This is a hard set of problems. But we're going to teach Wotton about medicine, and we're starting with cancer. Right? And Wotton for Healthcare will be a service available to solutions and partners solutions that our partners will develop. So the Wotton for Healthcare system, represented by the platform on the bottom, is fed with, as I said, effectively all medical information known to man over time. We then develop solutions. Our first solution that is geared towards the treatment of disease is an oncology diagnosis and treatment advisor, which we'll talk about for a few minutes here. The users of these systems are healthcare providers, and we will make it available to healthcare providers for free. Okay, we're going to make these systems available to healthcare providers. Health plans, the folks who underwrite the cost of healthcare, ranging from all U.S. private healthcare plans to Medicare to government systems in other countries, we believe will pay for this system because it will deliver better outcomes. Better outcomes based on evidence. So this is a journey that we've started, and Harlan will talk about, my colleague from WellPoint will talk a little bit about this business model. But we are building these platforms that will take patient health information. Right? So any solution to treat a specific patient. So let me stop for a second on that one. We're not talking about a system in which you query the way you would query a system today about a particular condition or particular disease, and you get some general answers. You get some guidelines. Well, that's a nice start, but that doesn't treat me. My condition is specific to me. And if the system knows about my data and me and all my lab tests and the observations and my medical history, then the chances are that I'm going to get a more targeted therapy, a targeted diagnosis and a targeted therapy. And that patient and health information is required. So Harlan will talk a little bit about creating longitudinal patient records and leveraging electronic medical infrastructure that is beginning to be prevalent in our society. So this is a schematic of the solutions we're building. Let me talk a little bit about oncology diagnosis and treatment. We've been working for a year to start to develop this first solution. It will treat cancer. We started with the solid tumor cancers. We started with breast and lung, and we want to get started on prostate very soon. This is an interactive advisor. This prototype iPad application is indicative, and Howard will say a few words about it in a few minutes. It's indicative of the kind of interface we believe. This is an interactive advisor to help a clinician diagnose and treat a disease. It won't tell you what to do. It can't tell you what to do. But it can get involved in the conversation of treating an episode and indeed ongoing treatment. And Harlan's going to talk a little bit about this. We think it's crucial to link treatment recommendations to authorization. So currently in the U.S. healthcare systems, major treatments, of course, are approved according to healthcare policies of the health plans. We're working with the health plans so that if evidence says this is the right policy and this is the right treatment, it's authorized. So we can eliminate a lot of waste that exists in the system today. We're expecting to begin piloting this system in the fourth quarter. We'll be giving it to a select set of clinicians. Over time, we'll expand it to begin figuring out how to make this system right. It'll take a while. In my view, it'll take most of 2013 to try to make a system like this work right. The reception we've had from clinical institutions has been overwhelming. People want to help, they want to try. I'm hoping that as we start our prostate cancer work later this year, early next year, we can involve some of you in that work. So I'm going to stop there, and we'll run a video, and Howard will talk for a few minutes about the actual interface. So.
Memorial Sloan-Kettering Cancer Center and IBM are at the forefront in building new technology that will use IBM Watson and complex analytics to better treat cancer patients. With medical information doubling every 5 years, finding new ways to make evidence-based decisions has never been more critical.
When I started doing cancer medicine, it was all about doctors' opinions. It was opinion-based medicine. And I was able to see a revolution in medicine based on evidence. In other words, doing clinical trials, gathering scientific information, and using evidence-based medicine for making decisions. So we have the opportunity now of going past intelligence into what I would call wisdom. And that wisdom is really in our medical records. That wisdom is really in the way really experienced doctors who specialize in diseases make decisions based on guidelines, based on evidence. So what Watson's going to enable us to do is take that wisdom and put it in a way that people who don't have that much experience in any individual disease can have a wise counselor at their side at all times and use the most experienced people, the intelligence and wisdom of the most experienced people to help guide decisions. I think this is beyond an evolutionary step. I think this is a revolutionary step. I think that if properly applied, this has the potential of totally changing the way we conduct medicine.
Watson is a tool that processes information, fills in the gaps of human thought, doesn't make the decision for you. That's the realm of the clinician, or the clinician in combination with the patient. But bringing you the information that you would want to have anyway to make that better decision is what Watson will do for you. Now, we're in a situation where the providers will benefit, the patients will benefit, and our technology is going to support them.
Watson's capability to analyze huge volumes of data and reduce it down to critical decision points is absolutely essential for our ability to improve on our ability to deliver effective therapies and to actually disseminate that information to the world.
So what you've seen is just an example of what we see as the vision for the future. And what Larry Norton clearly emphasized is how do you translate clinical experience, the plethora of information that's available in the way individual doctors have managed their patients, to better understand outcomes. Now we're in the area of clinical utility. How do you show that the molecular diagnostic tests that are expensive, how do they in fact add to the management of the patient? And I would argue it's going to take a combination of all of these factors in order to really, really improve our outcomes. So what we focus on is what is the value to improve outcomes, not only in terms of an individual patient, but also to better inform and prioritize research and to train the next generation of physicians. How do we translate thought leaders and experienced clinicians' experience to apply this intelligence on a more global scale? How do we incorporate the recommendations that are part of guidelines, both our own and other national organizations, including NCCN and ASCO? But more important is how do we get the best available evidence in order to support our decisions? And a key point is Watson is not a substitute for the doctor, it is an advisor. But in addition, we will be able to look back on how the management of individual patients within one of the disease states has been affected by some of the newer treatments. And I'll give you an example of this from our lung cancer colleagues. So again, what we're looking for is an intelligence engines that will better inform our treatment recommendations by aggregating information from anywhere that may impact on that therapeutic decisions. And again, what we're trying to do is to get information on what is the best decision for an individual. So some may ask, why not start with prostate cancer? But as you learn, Watson has to be trained. And the more dichotomous the decision that you are informing, all or none outcomes, the faster the learning can be. And unfortunately, in prostate cancer, some of these decisions are not as clear-cut as finding the presence of a tyrosine kinase mutation in lung cancer, where unfortunately, if a patient recurs, the prognosis is extremely poor. So here's an example of a young woman who is diagnosed with adenocarcinoma of the lung. And here you see a screenshot of the typical information that we might have at a first consultation, including a pathology report, imaging studies to show the extent of disease, and the fact that she was not a prior smoker. So at this point, it's really too little information in order to make a decision on how to approach this individual case, where the recommendations can range from chemotherapy to a targeted agent, olatinib, that affects tyrosine kinase signaling. Similarly, there's not enough information to recommend enrollment on a specific clinical trial because not enough is known about this woman's individual cancer. But Watson can also suggest additional tests that might help better inform this patient's decisions. So the recommendation was perform a molecular pathology panel in addition to some of the routine staging procedures that we do to better understand disease extent. And in point of fact, this particular patient was identified to have an exon 20 insertion mutation in the EGFR receptor, which predicted for a lack of response to erlotinib. And you'll see that now the recommendation can be made with greater confidence that using a drug such as erlotinib is not appropriate or may not be the best option. So she was advised to have a cytotoxic regimen, which included cisplatin, pemetrexed, and bevacizumab. But again, this type of system also gives us the opportunity to look how a new therapy has impacted on management and also can help us guide future trial questions. So on the right-hand side, you see the results of a clinical trial which evaluated a new cytotoxic agent, pemetrexed, in patients with non-small cell lung cancer. The trial was positive. This was a combination study versus gemcitabine with cisplatin in patients with lung cancer, showing a survival benefit. And then looking back, after the drug was approved, at a series of patients who were treated at Sloan-Kettering with their outcomes highlighted in blue. Now, granted, this is a retrospective study, but again, statistical modeling was applied to match patients within these cohorts. But you can see the outcomes with the new agents essentially, when applied in clinical practice, essentially mirrored what was found in the clinical study. So again, one can envision if there are a range of different therapies and the population is large enough, we can begin to get insights as to which treatment is actually impacting on the disease and to get some insights of perhaps which agent might be used first versus second. So the opportunities to me are essentially limitless. So as we've illustrated, we can now see how a new therapy has impacted on practice. We have the opportunity to look at the totality of the population, not just patients who go on trials. We can use this to understand individual prescribing patterns. How do individual physicians use particular tests and how do they impact on management? But importantly, I think this will also help us prioritize questions for exploration in our future clinical trials. Okay.
I'd like to introduce my partner and collaborator in this journey, Dr. Harlan Levine. Harlan is the Executive Vice President for all the clinical operations at WellPoint, the largest Blue Cross Blue Shield insurer in the U.S. I believe you insure about 34 million members. So we'll run a video, and Harlan will share a perspective with you.
WellPoint is one of the nation's largest health benefits companies, and we actually serve 1 in 9 Americans. That's over 34 million people. Healthcare is very complex and always evolving. We're faced with cataloging and categorizing an unprecedented amount of information right now, everything ranging from clinical guidelines to patient records. And today, doctors are prescribing evidence-based medicine only 55% of the time. So at WellPoint, we're there to help make sure that our patients have access to the best quality healthcare and evidence-based healthcare. What Wotton can do is help us match up all the new discoveries and new clinical information and present that information to our nurses in the context of an individual patient. The part that really makes it stand apart is the fact that it can process natural language. In that way, it's even more useful to our nurses. Our WellPoint clinicians have worked with IBM technologists and processed 25,000 historical cases to help teach and train Wotton. To date, in our pilot, we've used 1,500 real-life cases and run them through Wotton. I think the biggest advantage of Wotton is it allows our nurses to work with the provider to make decisions more quickly. Today, what IBM Wotton does is it takes a process and makes it more efficient. I can see in the future that not only can it make the process more efficient, but it can actually lead to better decision support, both for providers and one day for individual members as well. Good morning. Every time I see that video, it reminds me that I want to have Wotton learn to replace me doing videos in the future. Well, thank you. It's really a pleasure and an honor to be here, and I want to thank IBM, the Prostate Cancer Foundation, and the entire Milken Institute for the opportunity to talk a little bit about how we look forward to teaming with IBM and Wotton to help fulfill our mission, which is to improve the lives of the people we serve and also the health of our communities. When you engage with so many members, like you heard, 34 million people, it's such a tremendous opportunity and even an obligation that we feel to really improve healthcare in the United States. And we're so excited about the Wotton opportunity because we feel like it's one of those unique technology solutions that can really make a difference. And what we want to do with the technology is both help ourselves operate better internally, but also help us engage more productively with the provider and help to enhance the provider and patient relationship. It's a much different topic for another day, but as we look to our future at WellPoint, and every payer should be thinking the same way, our value going forward is how we partner with the provider system. It's not about insurance and financial arbitrage anymore. It's really about partnership with the delivery system. And we see Wotton as an opportunity for us to make an investment in that future partnership. So there's a lot of work to be done here, but we see that Wotton can be very influential, quite simply, in just making things work better. So let's start with how we're using Wotton internally to improve our own processes. Today, we employ 3,000 nurses, and while many of these nurses are frontline, working with patients, helping them manage their condition, and helping them with disease management and case management, many of these nurses are also performing a function called utilization management. And for those of you who don't know what utilization management is, that's that much beloved function that we serve, where a doctor or a patient requests a test, and then we look through work through a set of processes and determine if the test is appropriate, covered, and safe for the individual. It's a very manual process, very labor-intensive. A nurse will review a case, collect information on the individual, then we'll look at clinical policies, we'll look at national guidelines, we'll look at evidence-based medicine, we'll ask questions, and then we'll arrive at the best decision. This process has been performed the same way for the 23 years that I've been a doctor, and I'm assuming that it's been the same function that's been needed since, I guess, since doctors stopped using leeches on patients. So this is an important process, but it hasn't advanced very far. And we see that there's an opportunity to apply the intelligence, the machine learning of Wotton, to bring it to a different level, to make it both better for ourselves and for our providers. What it does for us is it streamlines the pre-certification process. So if the information is complete, we can give an automated answer to the physician. It also, as you heard earlier, allows us to identify where information is missing. And this is a key because oftentimes there's time lost between an answer of no without really knowing why the answer was no. So we're able to get the information back to a physician and speed up the process. It also helps in what we call post-service review. Frequently, a procedure is done because either it missed the process or was considered urgent, and then we have to do a review, and there's so much more information to review, and through a functionality that I'll describe in a moment, we're able to collect all the information and be able to render an answer, and what that does is it takes time, it gives time back to the physician, they're not engaging with us, and they can spend time taking care of patients. One of the areas that we're really excited about is the opportunity to enhance self-service. And what this means is a doctor can work in an intuitive fashion from their office, submit the information, avoiding a fax and a phone call and back and forth information, and we can get to an answer quicker than we could before. We've done as Dan mentioned a few minutes ago, we've started a pilot with physicians through a portal, and they love it. The initial feedback has been very positive. And the reason for that is clear. Up until now, has been an administrative burden. The answer has come back yes or no. But with the Wotton technology, it's not just yes or no, it can be no because, and here's what's missing. And think about the enhancement this can make in practice. So today, a lot of times, a test like an MRI is performed, and a few things can happen. Number one, the MRI has already been performed by another doctor, and the doctor's not aware of it. Well, we can pull that information in and share it with the other provider. Another time, the MRI might not be the right test. It may be something they heard about or learned about recently, but we get better results from doing an ultrasound or a CAT scan. And the reverse is true also, by the way. A lot of physicians are trying to be cost effective, and they'll order an ultrasound. And we know, and Wotton can help let the doctor know, that the ultrasound won't really change therapy, and you're ultimately going to need an MRI anyway. So for the first time, this process can be real time, and informative back to the physician. And when you have better information, faster responses, the patient, the provider, and the health plan will all benefit. So let's switch gears a little bit and talk about what we're doing with IBM and Sloan-Kettering in oncology diagnosis and treatment. I think Howard described it quite well, so I'm not going to repeat the details of these 4 areas where we're beginning our focus. The main points I'll highlight are we're not concerned about what's going on in the major institutions in the country, but a lot of cancer care is delivered in the community, and as you heard, there's a lot of physician extenders in addition, and we worry about, as you move out from the institutions, you're getting a high degree of variability in the consistency and quality of the health care. So what this allows us to do is equalize that. We're able to get the information out to the providers as if they had second, third, and fourth opinions behind them. Also, to highlight the point that the information in cancer is changing rapidly. You heard about the predictive modeling and the personalized medicine that Howard described. The genetic markers that are emerging every day there's no individual that can keep up, and quite frankly, the science is changing. I remember when I started practice 20 years ago, the IOM came out and said that it takes 17 years from something to go from medical fact to practice. And while we all like to think that's significantly better now, the most recent literature I've seen still says it's over 10 years for that to happen. And Wotton gives us an opportunity to bring evidence-based medicine best practices, national guidelines, and link it to an individual in the most appropriate way. So a doctor's not remembering something that they read that was appropriate for a 59-year-old white male when they're trying to treat a 30-year-old African-American woman. And we also like the potential for Wotton to personalize treatment that goes beyond just the clinical facts. As you all know, when you're treating with chemotherapy, there may be equally efficacious regimens out there, but they have different impact on the individual. So Wotton can take in the information that you heard, the unstructured data, be aware of a person who may be a musician or may be a skilled worker who has a preference for chemotherapy that would have a side effect profile different from one that causes neuropathy, nerve damage. So these are the opportunities for Wotton today in oncology. When we achieve these simple milestones, we'll move on to things that are more complicated and bring in things like better comorbidity analysis and being able to match people to clinical studies. So this is all good. But the next challenge we had was, how do we bring this into the doctor's office or make it bedside? Well, one way, as you heard earlier, is to link it to the utilization review. So if the doctor knows if they're prescribing the right medication, they're following the recommendations or not, but they're using the tool, they can get paid quicker, and then they don't have to have all the administrative burden. But the other way of doing this is that we're layering around the IBM Wotton tool a solution called the WellPoint longitudinal patient record. And what this is briefly is a electronic record that goes beyond a single source of data. So it pulls in the information from the doctor's office, from the hospital, from the laboratory, from personally inputted information that a patient might do as they check into the office or perform a health risk assessment. And it brings it all together. And it brings it together in a way that is meaningful to a physician. So how is this different from electronic medical records that are out there today? Let me highlight a few areas. First of all, this tool also has electronic prescribing capabilities. So a doctor from the same record can prescribe and get the advantage of patient safety alerts and dosage recommendations and cost-effective feedback, which formulary someone is in. It also has rules engine running in the background. So if someone is missing a test that's recommended by evidence-based medicine for the condition or for preventive health, it can bring that to their attention. But more importantly than that, where this is different from what's out there in the market today is, one, it has multiple sources of information. Two, it has a very sophisticated, what we call clinical ontology, not oncology, ontology, where it structures the information in a way that makes sense to a doctor. So instead of having bits of information like a PSA from 3 years ago and 2 years ago and 1 year ago mixed with radiology results and then a unrelated broken arm from an accident and chemotherapy regimens over time, it recognizes the episode of a cancer treatment, and it presents that information in a way that a doctor can say, aha, this is what's happened. And whether it was they who performed it or 3 other oncology offices or private offices before it came to the institution, it pulls it together. So we think when you take the combination of the single best medical record, clinical rules to identify care opportunities, and really state-of-the-art decision support, not physician replacement, but decision support to give meaningful information to a physician, you're going to lead to what we call the Holy Grail, which is more affordable, higher quality, and more convenient care for the individual. So thank you for your attention, and with that, I believe I'm going to turn it over back to Dan and
Put the next slide.
Back to Dan.
So we're just, we've been told we have time for a couple of questions. So as you can see, it will take a lot of work to get this done, but we're well on our way on this journey. So we hope you'll follow us, and we hope we'll engage with you over time. So I think we have time for a couple. Is that right, Howard?
Obviously, this is the future of medicine, and this is exciting. I just have a couple of questions for you. What is the danger that the engine light will come on everybody's dashboard and we won't know what to do about it? That's one of the dangers. And the second one is, how do you back test this and beta test it? Let me give you an example of the other type of danger that we have to worry with. The most common personalized medicine test in the world is the most accurate, and that is taking the temperature of the patient when they come into the doctor's office. And yet after all these years, we're finding out now that we use that incorrectly, and that a low-grade temperature is beneficial. American Academy of Pediatrics shows this, and yet we all run out and apply aspirin. So the thing would say, give the aspirin when you have a low-grade temperature. Can you test the past medical records and find out where we've overtreated, where we've made errors, how we could have predicted toxicity before the drug's taken off the market in a bigger test? In other words, using it, back testing it to validate it. I know this is a big question, but it's a worrisome question.
I'll give
we
you
need a
the second
user's
one.
manual when that light comes on.
Thank you. If the information is there, it can be tested. But I would argue in a patient who's undergoing multiple treatments, is on multiple therapies, it will be hard to ferret out whether the aspirin was the sole contributor to that individual. But in point of fact, with the information, you can do retrospective analyses. I did show one example, for example, of the impact on treatment. But essentially, I agree with you that there's so much information that we haven't even begun to mine and look at just on routine practices. What about somebody who's taking aspirin, somebody who takes Tylenol, someone who's on a non-steroidal? We know there are a lot of medications that people are taking that can modulate the immune system. We've never even thought about it. We're certainly just beginning to look at how to measure it. We understand that the microenvironment is important, but again, before you pose the question, it's very difficult to answer it.
Yeah, I would answer that in two ways. It's a very good question, and it's going to be one of the challenges of any system. I would answer it in two ways. One is, I trained in the 80s, and I recall that everything I learned in the ICU in managing cardiac arrhythmias not only was wrong, but actually led to more deaths than benefit. So I understand the power and the dangers of information. What I like about the Wotton tool is that things do change rapidly. And there are very few tools out there that aren't static and get outdated very quickly. And this is a continuous learning opportunity where as information emerges, it can get put into Wotton and then get disseminated as best practices. And we aren't, I work at an insurance company, so I'm not there to establish best practices. I'm trying to enable the ability to have best practices. And then the second point is, the reason why we partner and why IBM brought together an academic institution, a leading academic institution, and a payer is that we do want to partner and study the impact of what we do and collect that data and have a continuous learning loop back into Wotton so we can continue to improve. But it's not going to be perfect at the beginning, which is why we call it a decision support tool, not a replacement for the clinician and judgment.
I'll just amplify that point. I'm not 100% sure what you meant by the engine light. But systems fail every once in a while. I think it's important to understand that our entire vision is, as Harlan has said and as Howard said, this is an advisor. This is a system that is in support, and Howard and I are fond of talking about a system getting into the dialogue between clinicians. It's a system, and it's there, and over time it will improve. The recommendations made by this system will ultimately be input to a clinician's, a doc's decision. And we are using clinicians and docs to vet this system, right? So we have an extensive testing process. And as I said, it'll go through years of improvement. So.
And again, you have when a decision is suggested, you do see the supporting evidence around it.
Right.
So you do have the opportunity, you can say, it's a 50% response rate, that's based on 2 patients, you can weight it. And part of the training process, again, is we will make recommendations of what we consider useful information, not information, et cetera. It's not a categorical, this is it.
A couple more quick questions.
Thank you. Great system. I was just curious, how do you collect the data to build your database, and how often update the database, and how soon the feedback from the physician is available for other doctors?
Okay, let me give you the general philosophy. It's not easy, and we're relentless about it. So we have a process of identification of medical information that would be relevant as a base for this system. And we've literally identified on the order of 248 sources just for our early cancer treatments. And we go out and we talk to people about that information. And then, as I said, we write annotators and we ingest that information. We're not sure yet how frequently it will be updated. It will be automated, though. But this is not the kind of thing that's updated daily. You should think in terms of months and quarters. That is a base of information. The clinical data is tougher. The clinical data is what we're working with our institution, clinical institution partners. And that data will be vetted and fed into the system and used dynamically. And I don't think we know yet. I think it's fair to say we don't know yet how much vetting the information needs and what processes would be used. Plugging in, as Harlan said, to a rich longitudinal patient record is, at a minimum, way better than a simple EMR, a paper file, or nothing.
Right. Last question? Yeah.
Mr. Cerutti and Dr. Scher and Levine, as you develop the model for prostate cancer, I want to raise one issue which, as advocates, comes up all the time, which is that prostate cancer is a little different to many other cancers in that the treatment choice is not immediately evident, and many physicians will not recommend a treatment choice, whether that be surgery, whether it be active surveillance, or whether it be radiation. And one of the reasons is because the treatment choice is very much up to the lifestyle of the patient because of the comorbidities. And I just want to raise this issue and hear your thoughts, that it seems to me that Wotton is an incredible solution when a patient who's just been diagnosed doesn't know where to go and is mightily frustrated with the medical community because they won't tell him what to choose, can say, okay, I'll ask Wotton.
No, you won't.
Maybe
You'll ask your doctor.
Don will answer that with the engine light.
Yeah.
Again, I think this represents another very important area of information that goes into a decision. And I will typically ask my patients, what are the 3 things that are of greatest concern to you? And you'd be amazed at the range of answers that you get. But to understand a patient's therapeutic priorities, where they are, factoring in and quantitating what the comorbidities actually mean in terms of their longevity is probably not done as well as we could. So I would view this as really just another one of the important opportunities that Wotton could provide. Again, this is helping us to guide decisions, and I think it's the same for a patient. If somebody has equipoise in terms of what an option the options are, and they ask my opinion, I'll put my opinion on the table. But that, again, it's ultimately the patient who is being affected by that decision.
Just one quick comment. I know we're running out of time.
We're going to let Dan Zank.
Okay.
So you can't see from here.
Let me just make one quick comment, which is, this is the medical foundation of what Wotton is. We actually look at health in domains of health. So there's going to be a psychosocial, a psychosocial and a psychological and a financial domain. And if you think about care not being delivered by a single individual, but by a team of doctors. This system allows folks to go in and make sure that each of these domains are managed. So we did not represent the future thinking about the various domains of health, but I think your question about that is very relevant and really a great opportunity for Watson going forward.
I'm just going to add one more thing, just so you get a feel for how we're thinking about this. We have in our future plans, not currently under implementation, the notion of a patient preference factor. So we understand that there are factors that would change the recommendations. We don't know yet how to take information in there, but as I referred to earlier, social media information about the patient could prove some insight. So that's sort of how we're thinking about this solution evolving over time.
I'll make this point. Say I'm an ex-fused patient. What's the timeline for using Watson to direct patients to the right clinical trial?
You know, I
haven't started yet.
Yeah. Pardon me?
No, again, I can't say the exact timeline of incorporating molecular data and patient histories. You know, the prostate effort is starting later this year. And again, part of that will depend on some of what's really been groundbreaking efforts of my colleagues in the lung service and breast, where the data is more quantitative, not necessarily more quantitative, but the outcomes are more dichotomous.
Yeah, I think the answer is we don't know yet. It also, you understand, requires the information about the availability of clinical trials in order to do that matching, which is another, we don't know all the answers yet. So I think you can see that there's a journey here. There's a lot of work that we have to do, but we appreciate your attention.
Thank you.
I guess they want a no shot.